how to use that term. And those part of the disagreements is whether the term should be used functionally or substantively. And I'll explain that briefly in this way. The philosopher Alasdair MacIntyre, who died earlier this year, famously wrote, "I can only answer the question, what am I to do, if I can answer the prior question of what story or stories do I find myself a part." And if you think of religion in the functional sense, religion is the fundamental stories, the master narrative that you take to be the story, the true story, that makes sense of the world and our existence within it, what it means to be human, what we can reasonably hope for, and so on. If you take the term religion to be substantive, then you're focusing on those functional religions in that prior sense that address and feature God in a focused way, how God has been involved in the world that we know and in our own lives.
Great. Thank you. Dr. Stahl, do you want to talk a little bit about what you think of when we talk about religion?
Sure. I want to affirm that there are many, many ways to think about religion. And this is, again, something that many spend entire careers on. I want to, in addition to the sort of functional or substantive division, I'd like to focus on religion working in a couple of different ways. One is that alongside that sort of distinction, we could also think about whether religion is institutional or individual. Is it someone's personal individual beliefs, or is it something that requires belonging to a church, a synagogue, an institution of religion? And those institutions vary tremendously. Some have hierarchies, some are congregational, some sort of delegate things to individuals to work out for themselves. So, what I want to emphasize is variety. I want to also note that for scholars of religion, one of the ways there's often a way of comparing or making sense of religion is to think about three ways religion sometimes works: through belief, behavior, and belonging. So the different beliefs people hold, which may or may not be about belief in God. It could be multiple gods. It also could be about wrestling with God. It could be not a belief in God. And it might be that behavior or rituals or the requirements of religion are what matter to someone. And finally, it could be about belonging. That is, belonging to a group or a space in which people have shared beliefs. So these are some of the different ways religion can work. So it's tricky sometimes to talk about this. What I do want to add to this, though, is that in the United States, classifying something as religion matters, and it matters legally and constitutionally because religion is protected in ways other kinds of beliefs are not. And so the implications and consequences of something being religion, whether you agree with that definition or not, or you disagree or disagree with who's decided something is religion, really do have ramifications for how things work in American society.
Great. Thank you both. So, one of the things I'm hearing both of you talk about is how the meaning of religion differs depending on the patient or the person that we're interacting with. So, turning to the word respect, which is the second word in the title of our talk today, in medical ethics, we teach that physicians need to respect our patients' beliefs and avoid being judgmental, even when those beliefs or values differ from our own. So our students are taught that this helps support building trust and that patients will be more likely to engage with the healthcare system if they don't feel judged. How do each of you think about respect for patients who may hold different values or beliefs from your own? And that actually aligns with a question that just came in. So what do we do when religious beliefs might initially contrast with our own beliefs or with our best medical practices? How do we navigate that? Dr. Stahl, you're still on the screen.
Okay.
Why don't you go ahead, Max?
That's all right. I think there are a few things that are core to respect, and one is about seeing others as equally human, even when you vehemently disagree. And so, I think part of that is the importance of striving for understanding. You may instinctively react to something someone says in a clinical setting or elsewhere in life and be like, they're just wrong. Um, and you can have that view, but I think it matters for respect to take the time to think about how can you understand someone else's perspective? What do they think? Why? And why does it matter to them? What's the most generous version of their views or values? And could you articulate their views and values back to them in a way that they think is accurate and non-judgmental? Again, even if you know you disagree with them, I think that's important to be able to do. It's also really hard to do and hard to do well. I do think that in the clinical setting, two things to be really cognizant of are, first of all, the power dynamic. Clinicians have power that patients don't in a clinical setting, and that matters. And it also, therefore, leads to questions about whether, and this gets at that second question, what happens when values or views clash? One version at a broad level is, can you share goals without sharing the same perspectives or views? And sometimes you can, and sometimes that's going to be really difficult. So, one of the things then that gets back to is that power dynamic and who has control and power in that space and what that requires that you do, which I think we'll be getting to in a further question. So, I'll pause there.
I certainly agree with Dr. Stahl's what she said up into perhaps how we handle the fact that, as she said, there is a differential of power, and we'll talk about that more. But yes, respect. Well, I'll put it this way. I think it's a mistake to teach students that we should respect patients or one another's beliefs. Generally, because the reality is we face in one another and in our patients beliefs of all sorts, some of which are not worthy of respect, frankly. Rather, I think the point, the ethical point we want to emphasize is that we owe patients, we, we, we should respect patients. We should treat patients with respect. We should respect them even if we can't respect some of their beliefs. Um, what does it look like to respect a patient? It's to treat them with serious moral regard, um, to basically, in the ways that Ronit described, I think, taking seriously what they bring, what they say, enough to seek to understand it, and, as she said, put it in a charitable framework as best you can. I mean, how can you construe what the person believes or wants, says they want, in a way that presumes good faith until there's really strong evidence otherwise? And I think it's that is behind the worry about judgmentalism. In my own view, I think we have too often in modern culture come to equate disagreeing with patients with being judgmental toward them. And I think, is properly understood, the problem of judgmentalism is the problem of presuming that a patient has a bad will, basically, that they have bad motives for what they are doing or what they believe, that they're not acting in good faith. But you need not be judgmental in that sense to say, I'm pretty sure I disagree with you about that. Help me understand why you think that, and can we argue about that respectfully? Patients understand that not everybody agrees with them in the world, and I don't think it need to, nor does it practically trigger distrust for patients to see that a doctor takes them with sufficient seriousness to indicate that they disagree with them about something, and because they're concerned about the patient and they take them seriously, they want to explore the nature of their disagreement.
Thank you both. And I think moving on to that last word of responsibility, I think it ties together a lot of the things that you're talking about. So I want to hear from each of you. To whom are physicians responsible? And what do you see as the key domains of that responsibility? Dr. Curlin, you're on the screen.
Sure. So obviously, doctors are responsible to their patients. They're responsible, in my view, toward their patients to act in a way that's conducive to preserving and restoring the patient's health. within reason. They're obligated to respect the limits of the physician's authority to tell the patient what to do. But they're also responsible to refuse, in my view, to do things when requested, either by superiors or by patients, that as best the physician can tell are not compatible with good medicine. And of course, physicians in their relationship with patients are accountable to the other demands of morality, of ethics, which includes fairness, truth telling, avoiding invidious discrimination, and a number of other norms that are just ethical norms that I believe, are bear on all of us. Um, we're also responsible to the public. We're responsible to the public to fulfill our profession, what the public reasonably takes us to be committing to when we put ourselves forward as medical practitioners. I think that means we're willing to show up, and we do, in fact, show up and with due skill attend to those who are sick and injured. Again, within reason, within our own context, insofar as we can, notwithstanding, limits on that and so on. But we're characterized by showing up in that way. It involves telling the truth, not taking advantage of patients, and so on. So, in a summary, we owe to patients and to the public to be good doctors.
All right. I think in many ways at the broad level, Dr. Curlin and I agree, which is to say, I do think there is a responsibility to a patient, to their goals, to their health. And I suspect that one of the ways we may disagree, and I think one of the spaces that is exceptionally challenging, is that health can mean a lot of different things. And patients have views about what their health is, what their goals are. Clinicians have ideas about what health is and what they can do. And I think that's the rub, is that it's one thing to say that there is a responsibility for a patient's well-being, for their health, for what they need, but there may be disagreement about what that looks like, what those end goals look like. I also think that clinicians have a responsibility to the profession, and this is part of a responsibility to the public in terms of what the public sees a doctor or a nurse or a pharmacist or any other clinician doing. And I think this holds for other professional roles as well. The public does have ideas about what that scope of practice is, not necessarily in a technical sense of scope of practice, but what is it that a doctor does, for example. And at the same time, we're living, and I want to acknowledge, we're living in a moment where expertise is under a lot of critique. And so this idea of people holding particular expertise where they may know things that others don't is a challenging line right now. I do think when it comes to responsibilities, that there are sort of bare minimums that matter in both of these realms. With regard to patients, I do think, to go back to what we were just speaking about, non-judgmental responses matter, which again is that I think a patient shouldn't feel that they shouldn't feel that someone has completely misunderstood them. Again, that doesn't require agreement, but it does require taking them seriously. I also think it's reasonable for a patient to expect that a clinician is going to give them accurate accurate information for at the moment. What is accurate, of course, in 2025 is different than what was accurate in the year 2000. So part of that is an obligation to obviously be maintaining expertise within the profession, knowing what the current standards of care are. And then part of that is relaying that accurate info, may be also identifying what a clinician can and can't do. That is both within their scope of practice. And when there are spaces when it is beyond what they do, and then this is where it gets really tricky in spaces of religious or moral disagreement, I do think there is a duty to refer, at the very bare minimum, that if a clinician can't do it themselves or won't, that they must refer refer, and they must do so in a way that doesn't make the patient feel like bad about what they are asking for, assuming that that is something that is within, again, the standards of care. And so that to me is also part of the obligation to the profession of professional knowledge and expertise, but also the choices any of us make upfront about what we go into professionally. I think that there is an obligation to choose domains, to choose specialties where you can provide a full scope of practice, and that you're not going to be in a space where you are regularly, consistently in a space where you're objecting or refusing something that a patient reasonably wants. And I think that probably there may be disagreement over what a sort of reasonable desire or reasonable want is, but I do think certain specialties come with different ideas about what that's going to look like, and that matters for the choices people make up front about what they decide to pursue professionally.
Great. So building on all that, how do you think physicians should respond if a patient raises an explicitly religious or a moral concern about their medical care? How do these concepts of respect and professional responsibility intersect in these types of moments? Dr. Stahl, why don't you go?
Um, so there are a lot of different concerns a patient could raise from their own vantage point. And I think part of then the obligation and in terms of respect is to ask what then a patient needs to know. What are they seeking? If they have a religious or moral concern with a treatment, with an option, what information would be helpful to them to be able to work through what what they're grappling with. I think it's also reasonable to think about who they're able to discuss this with, which may not be the clinician, which is to say, sometimes the clinician may provide information about options, for example, and then someone may want to consult with others, with family, with friends, but also, of course, with a religious leader or clergy or a trusted member of their congregation. And so, to recognize that every decision that anyone makes has trade-offs, right? And so, one of the questions for a patient may be what trade-offs are worth it for them. And those can vary, and we may disagree with those. When I was teaching medical ethics in medical school, one of the things that I know students really found frustrating, for example, is sort of the classic one, which is Jehovah's Witnesses refusing blood transfusions. And they get to make that decision for themselves. But it also may be the case that there's a Jehovah's Witness who wants more information. And it might be someone who is struggling with their own faith, and they may be struggling with the decisions they make in a particular moment. And what they may therefore need are different things from different people. So, what is the information a clinician can offer that then lets a patient make a good decision filtered through their own religious and moral values?
Yeah, and some agreement, some disagreement, and how I'd approach that. I'm a palliative medicine doc, and so when I hear the question, how should we respond when patients raise religious or moral concerns, the first thing that comes to mind is patients or their family members who are very sick, talking about trusting God, hanging in there, knowing that God has a plan, that I'm not gonna give up too early. We're praying sort of people, and so on. And I think one of the first things that comes to people's minds when they think about the intersection of religion and medicine are those situations where patients use religious language to make sense of their insistence, for example, that medical efforts continue for someone who's critically ill. There have been some studies of this. Had a privilege of participating in one with Doug White and Natalie Ernikoff and some others a few years ago, where they recorded um, conversations between physicians and family members for people critically ill in the ICU. and recorded lots of conversations across many different institutions. And what they found is that doctors almost never ask about religious or spiritual concerns in those contexts. And when patients or their family member, well, in this case, it's just family members, when family members voice them, doctors tend to just ignore it. So family may say something like, well, doc, we're just all praying together, praying for healing, trusting that's going to happen. And the doctor will say, well, the kidneys, tend to are not looking good still, or we're going to do some more diuretic or whatever. Um, so I think the first thing I'd encourage students, future physicians, current physicians to do is pay attention and take people seriously enough to say, I hear you saying that. Tell me what you mean. What does it look like to trust God? What do you feel like at this point God's asking of you? Uh, just out of what Dr. Stahl described earlier, a genuine interest in understanding rather than just coming to some conclusion that may not really reflect what's actually going on for the patient or family member. So that kind of seriousness, certainly. If a patient raises a moral concern or basically is in a situation where they may be conflicted or not, the physician may be conflicted or not, but there's something morally at stake in this decision. It seems to me physicians owe patients candor, respect, and an honest appraisal of, to the best of their ability, of what's themselves ethically at stake in cooperating with or not cooperating with the patient's request, including the question of whether what the patient's requesting is something that a doctor owes by virtue of their profession to be a physician or does not, which of course depends on some kind of account of what medicine is and what doctors reasonably profess. But they need to come to some conclusion about that, act in a way that they believe is morally upright, it's has integrity, and explain that respectfully to the patient. Sometimes that involves negotiation with the patient. Sometimes it involves, sincere disagreement, and sometimes it just involves saying, "I can't help you with what you believe you need." Um, and and I cannot do that because as a matter of my understanding of what I'm committed to as a physician, what you're asking for is something I shouldn't do. We often call those conscientious refusals. Dr. Stahl and I have both written about these situations. Uh, but in my view, in those situations, the doctors just need to be candid, respectful, tell the truth, and do their best to fulfill their obligations as physicians.
Thank you. I want to dive a little deeper into the discussion around praying with patients. We've had multiple questions come through already asking how to respond when a patient asks, Doctor, can you pray with me? One of the questions asked whether if the patient and the physician share the same religion, if it's appropriate to pray together, or is it a misuse of the power that we discussed earlier? So how do we approach these questions about prayer?
I
Dr.
guess
Carlin, why don't you start?
sure, I'll start. So in my view, the answer would be sure, have at it. This is an area of total freedom. The standard against which the doctor should hold him or herself or the medical student is my action in this case going to interrupt, contradict, or in any other way frustrate my commitment to the patient's health? Is it going to make it hard for them to trust me, et cetera? But if not, it's an area of freedom in the same way that doctors can talk to patients about all kinds of human things that are relevant to one or both as part of their meeting as fellow humans. It's certainly permissible to pray with patients. You should do that only if you can do that with integrity, and you should do that only in ways that are, hopefully wise. But you're never going to figure out how to do that wisely if you never do it. So, I mean, one of the things that I would be concerned to communicate, since I have a chance to talk to your students, is that there is, in my judgment, no good ethical argument for why it's a violation of professional boundaries to pray with patients. I don't, I have not seen an argument that seems to sustainable to suggest that. Clearly, there are ways you could pray with a patient that would get in the way of being a good physician. But I presume students don't intend to do that. And so I hope they will, by practice, learn how and in what ways it's fitting to talk to patients about spiritual issues and to pray with them.
Um, I don't, I would say that this is an area where there can probably at sometimes be personal discomfort, but sometimes we have to, professional standards require us to overcome that. And what I mean by this is you may know that your patient believes something different than you, or believes in a God that's different than yours, or you may not believe. I will say that I'm answering this question assuming that it is something the patient has requested. I do think that the line I would draw is that it is a very different circumstance if a patient has requested that you pray with them than to be the person, the clinician, the one with power in the room and say, let's pray on this, right? Who that request comes from, I do think matters significantly. If a patient requests it, the way I think of it is that it is like going, if you go to someone's house and they say grace before a meal or grace after the meal, or you go to a funeral and there are prayers that are part of a funeral that you are, as someone who is there participating in, that doing those things is respectful, that you don't disrupt the grace before a meal just because you don't usually say it. You don't disrupt a funeral because people are praying together in ways you don't typically pray because it's not your beliefs or your rituals. So to engage with someone is to me is to respect their beliefs. I do think it's important, of course, to be clear, as Dr. Curlin was saying, in your communication, certainly in terms of not um, sorry, um, over promising, right? That this is something you're doing with someone, but it is not something, if it's not something you believe, but you're doing it out of respect, you don't need to tell someone you're doing that. But you're engaging with them. Maybe, you're thinking whatever thoughts you're thinking in a particular moment, but what you are to them is respectfully participating in something they have asked. And that to me is about how you respect someone. And again, you may have very different beliefs and very different ways of praying. People pray very differently. Different traditions have very different prayer rituals. But silence when someone is praying, taking that moment is to me always, a respectful thing to do. If they're asking you to say words that you don't feel like you can say, I think you can say, I'm happy to join you in silence while you pray, right? That is a way of, I think, respectfully honoring someone's desire to pray in a particular moment. If you feel like they're asking you to say something that you can't, with integrity, speak. But I think there are a lot of ways, again, I would frame it as what are the ways we participate in religious rituals that are not our own necessarily, but do so with integrity in all sorts of venues. And we can import those respectful encounters to an interaction with, again, the patient has requested.
Thank you both. So I'd like to get back to something that Dr. Curlin mentioned, that physicians are commonly more comfortable talking about, say, the kidney than perhaps talking about a patient's religious or spiritual beliefs. Later today, our students are going to be learning some techniques to start those conversations with patients, but I'm curious if both of you will share some thoughts around how we start learning about our patients' beliefs, whether that be religious or spiritual or cultural. What questions can we ask to start hearing those pieces of their identities? Dr.
Oh,
Stahl, why don't you? Oh, sorry, go
oh yeah,
ahead.
go
Go
ahead.
ahead.
Go
You're
ahead,
great.
Ryan.
You're on the screen now.
Okay, sorry. I mean, I guess I've thought about this a lot. I get asked this a lot. There are people who've put forward little tools that can help kind of break the ice, help you get the confidence to ask a question. One's called the FICA, which it's a acronym for asking about faith, asking about institutions, I believe, asking about I can't remember, but there's one called the hope questions. I personally have never used those. I just and I try to train my trainees to just look around and pay attention and be interested in your patients. So, for example, at least where I live and work, it's not uncommon to walk into a patient's room, as it happened last week when I was on service, with more than one patient, and there's a big Bible that's well worn right there on the bedside table. You can just ask him. I see the Bible there. Are you is your faith important to you? And then just stop and listen. Tell me are there particular passages that have been a comfort to you in this time, or how are you doing spiritually? What What do you feel like God has for you in this time? These are questions I've learned to ask that don't presume a right answer, but they're just a part of trying to understand what's going on for the patient. And sometimes patients indicate with the first question they don't really not interested in talking about that further. And for me, that would be enough to not talk about it further, not ask anymore. But sometimes they just light up, and that becomes the point of human connection that just helps enliven their experience of being cared for, and frankly enliven the clinicians as well.
Agree. I think this is about understanding and it's about using cues. They may be visual, they may be verbal, they might be what someone, is wearing. They might be something that someone mentions and asking them about that. Again, not to assume it's, to sort of overstate the importance or understate it, but to be curious. And I think the capacity for curiosity is often what matters in these contexts. In the same way that it might be questions about, who do you turn to when you need to work things out, when you're trying to make decisions? Who do you have around you to think this through with, right? And that might be someone who's religious, a clergy person. It might be a family member. It might be a good friend. It could be all sorts of things. It might be just themselves. What are you trying? What are you, trying to work through? If a patient makes a request, maybe around it's, a holiday or something that they are seeking. Um, what's the possibility and plausibility of helping them access those things and then using those? Tell me about that. I've never celebrated that holiday before. Just what do you do for that? What do you want to be able to do? I think those are important questions, and they may lead down religious paths, but they may not, right? I think the beauty of these kinds of questions and the importance of both empathetic listening, but broad curiosity is that you don't actually know where they're going to take you, and then being able to be responsive to whatever it is, which again might be religious, but it also might not be.
Thank you. So later today, our students are going to be learning that there are studies looking at the importance of talking about religion and faith on health outcomes, and that when those things co-occur, there are positive outcomes on health. So I'm curious if either of you can provide an example that stood out to you in your career when sharing a religious or a spiritual belief benefited the care the patient received. I know I'm putting you on the spot there, but do either of you have an example that you can share with us?
The patient sharing their
The patient sharing their religious or spiritual belief positively benefited their health outcome or the care that they received.
well, Ronit, something come to mind for you?
I don't have an immediate example. What I will say that did come to mind as you were speaking, though, was the broadly what this gets at is alignment, which is true in many contexts. In pedagogy, for example, when you're teaching, right, are the strategies you're using, the way you teach, do they align with or map onto the goals, right? All of us have had good teachers and bad teachers, and often what makes a teacher challenging is that there's a lack of alignment. So it makes sense to me, sort of intuitively, that that alignment could be beneficial. I don't have an immediate example that comes to mind, however. Do you?
Well, I mean, yeah. So now that you bring up alignment, I don't have um, one a particular example that comes to mind, but as I've gotten more experienced, more years under my belt practicing medicine, I will say I have pay more attention to and more freely engage patients about religious and spiritual concerns than I did in earlier years. And that's partly because have now a lot of data to suggest that almost always patients seem to really appreciate that. Um, and I have had a couple of patients. I have had an outpatient clinic for about 18 months, not long ago, dealing with patients, many of whom had chronic pain as well as other syndromes, often medically unexplained syndromes. And I found that connecting with them about the fundamental, lamentable reality that they have a kind of suffering that is, I'm not saying is not real. It is real. It's their experience, but for which medicine does not hold powers to relieve them, to deliver them. And then pivoting to that question of finding ways to go on that are more consistent with and conducive to their own flourishing than just spinning, looking for a medical savior from that syndrome. I have found frequently, or not infrequently at least, ends up talking about what's important to you. And if I've asked them about their faith and it turns out that that's serious to them, I'll ask them something like, what do you think God is calling you to in this season of so much suffering that you're having to go through? And then what steps can you take? And I find that identifying steps that can be taken that are proactive, that avoid medicalization that's actually making their syndrome worse, and yet are be able they can see as not me just brushing them off, but joining them in this hope for a more healing pathway for them going forward involves candid, serious, substantive conversation about who they are as a religious person and what the shape of their vocation is.
Thank you both. And we've been focusing a lot on the beliefs of the patient. We have a lot of questions coming in talking about the beliefs of the healthcare professional. So how should providers balance their own personal values, their own religious beliefs, and the risk of discrimination potentially against patients? So an example provided, people whose own values that are inconsistent with potential identities that the patient may hold, or specific interventions that the patient is asking for. How should clinicians balance their own beliefs against what the patient is asking for? Dr. Carlin, why don't you go?
Sure. Well, I don't think it's a matter of balance. I think balance is the wrong term. Um, Rather, it's a question of serious consideration of what is what is required of you, all things considered, in this situation, which includes considering whether what the patient hopes for from you, what they're asking you to help them obtain or asking you to provide, is something that you, in fact, should offer them or help them obtain. And whether you should or not is, of course, going to depend on whether what they're asking of you is required of you by virtue of your commitment as a physician. Um, I disagree with Dr. Stahl about the in principle obligation to refer. Certainly, doctors are obligated to refer anytime they believe a patient needs for their health some intervention that the doctor cannot, for any number of reasons, safely, effectively provide him or herself. Then we are certainly obligated to refer. I don't believe we doctors have, and they certainly historically have not been understood to have any kind of general obligation to refer people for those interventions that the people value and want, um, without respect to whether the doctor thinks those interventions are actually compatible with their profession as a physician. This comes up obviously with respect to hot button topics like referring for an elective abortion, referring for medical aid in dying, referring for medicalized gender transition, um, and so on. Um, and the argument is increasingly made by different folks, Dr. Stahl has been one of them, is that in such cases, doctors need to be careful to not let their personal values get in the way of them fulfilling their professional obligations to provide medicine according to the standards of the profession. And it seems to me that there's two problems with that way of thinking. One is it presumes that if a person opposes a particular practice, that that's a matter of a personal value rather than a matter of professional commitment, professional discernment, professional judgment. And I think that's not a sustainable assumption. Um, and the second is that it avoids giving an account of what it is that doctors are, and in fact, what it is that medicine's for, what we reasonably profess when we profess to be physicians. In my own view, which I've made an argument I've made at book length in a book called The Way of Medicine, is that medicine has historically been understood and should still be historically understood to be a practice that includes a commitment, a profession to show up, attend to those who are sick or injured, seeking to preserve and restore their health. But if a patient wants something that's not clearly required by that commitment, and certainly if they want something that there's good reason and longstanding arguments to that the thing they want, let's say an elective abortion, contradicts the physician's commitment, so understood, then the physician's not obligated to help the patient obtain that. And then we have to live with it in a world where we're going to face difficult and painful situations where sometimes our medical practitioners will not help us obtain things that some other practitioners would help us obtain.
So, as Dr. Kurlan noted, this is a space where we do disagree strongly. I think it's fair to say. And I think things like referrals matter in part because that is a way of honoring and respecting what a patient seeks. And I think there are obviously hot button issues on which these debates typically center, and they typically center on hot button issues because they are kind of these lively and things that make people react often instinctively. I think, however, that framing this comes back to something I noted earlier, which, and I think both of us in some ways have talked about, which is that um, just like the definition of religion can vary tremendously, so too can the definition of health. And so a patient and a clinician can, in fact, very much disagree on what sort of the ends of their health are, should be, what they look like. What I think is different and why I think the duty to refer matters so much is that when a patient goes to an OBGYN, I think they do have a reasonable expectation that that is someone who can help them with an issue related to obstetrics or gynecology. So whether it's they're seeking contraception because they don't want to get pregnant, or they're pregnant and don't want to be, or maybe alternatively they want to be pregnant and need something like IVF to access it. All of these are issues that people do currently disagree on. And so I think if someone chooses to go into OBGYN, they are placing themselves in a situation where they know upfront that patients are going to potentially seek these treatments or this care, and they need to be ready for that. And I do think forcing someone to stay pregnant is no better than requiring or not, that like the emphasis on refusing that treatment actually has a logical outcome that is disrespectful to a patient. So I think that's where these vexing issues arise. People can have personal um, and challenging moral questions around this. But I do think there are decisions people make in advance about the specialties they go into and knowing what patients would expect out of those. They don't, by contrast, go to the allergist expecting this. I once gave a talk and an allergist, I use allergy specifically because an allergist came up to me and said, this was really interesting, but to be honest, I've just never had to think about these questions in my career. So and I'm taking him at his word. I'm sure there are ethical conundrums in the practice of around allergies, but these were not ones that were central to him, and therefore they weren't ones he had spent much of any time deliberating. And that's fine. He made a different choice about what he went into in medicine. And so I think when you know someone's going to come and request that is within the scope of practice and standard of care for that specialty, that there is a duty to help a patient find the care they seek if you are not going to provide it. And I'll note also on this front that one of the really interesting things, one of the things I've written about which is related to this, is the question of IVF and the way it was handled, a comparative study of how it's been handled institutionally in American Catholic hospitals and Belgian Catholic hospitals. And in Belgium, you can access IVF at a Catholic hospital, which you cannot do in the United States. And one of the really interesting developments to me in Belgium was that the importance placed on ethical discussion rather than outcome, and that the policies and practices there really emphasize discussion and conversation rather than a set outcome. And I think that's something that referral creates the space for. If you're not going to do it, then helping someone get the access elsewhere matters. And this also is the practice, I will note historically, that in the 1960s, when a number of private hospitals provided the OBGYN service at the DC General, the public hospital in Washington, DC. It was something that Georgetown, which is a Jesuit hospital, Jesuit university, had to work out what would their clinicians do when they were on service at DC General. And one of the workarounds they created was a card. So they didn't verbally refer, but they referred via a card. So even there were like interesting ways that they worked out through, ethical discussion. How could they provide a service that would be reasonably expected at a public hospital for patients when their clinicians felt they couldn't do it? And so I think it's important to find those ways to provide care, and one of them may be via referral.
If I may just briefly, and Dr. Stahl and I could and have argued about this at more length than here, but I'll say I am every year, I work at the intersection of medicine, ethics, and religion. Every year, one or more trainees will reach out to me who finds OBGYN, obstetrics and gynecology fascinating. They love the practice of caring for women's health around their reproductive years and helping them get through pregnancy with their health intact and so on. And they're really interested in being OBGYNs, but they're also serious about an opposition to abortion and some other practices. Often they're religiously serious about their religious faith as well. And they ask me what to do. And I always tell them, please go into OBGYN because we need people within obstetrics and gynecology, as there are already many such OBGYNs, who in their practices show that you can be a good OBGYN if you understand medicine as it's been understood historically by being committed to preserving and restoring women's health in these years of the reproductive years and in going through pregnancy safely. And that your unwillingness to participate in a practice that for 2,000 years was uniformly opposed by medical profession, insofar as people talked publicly about it, does not mean that you're declining to fulfill your professional obligations. And just briefly, I know because I think it's important terms. Dr. Stahl used the term standard of care. There's a difference between scope of practice and standard of care. I agree with her that doing an abortion in the United States is within the scope of practice of OBGYNs, clearly, including surgical abortion. There is no jurisdiction in which it is considered standard of care requires you to cooperate in abortion. So it is the case that providing abortion is within what's permitted as a standard of care, but nowhere is providing an abortion or referring for an abortion required as part of the standard of care, nor has it been held to be such. So I want trainees to know that because it matters. If you think you're obligated to refer, you're not, at least under the law, and I think you're not either under the traditional norms of medical ethics.
So a lot of questions coming in about these topics. We're running out of time, so I want to spin this slightly. We've talked about the individual level. We've talked about provider clinician beliefs, and there's a lot of questions also focused on public health. One of you, I think Dr. Stahl, started talking about vaccines as one example, and the questions are asking, how do you respect people's individual choice based on religious beliefs when it impacts the public, when it impacts public health outcomes? Dr. Kurlan?
Sure. I mean, I'll say you don't need to respect their beliefs. I mean, patients, you can respect people without respecting all the beliefs, some of which are frankly terrible, poorly informed, irrational. And you can still know that you probably have yourself some poorly formed and irrational beliefs that you hope somebody will respectfully point out to you in some due time so that you can make good choices. I think similarly with patients, we go through taking them seriously enough to have a conversation with them and try to negotiate with them a way forward that we think is conducive to their health, respecting the limits of our authority. We don't have authority to coerce people to undergo interventions that we believe they should have, but we can respectfully present the case for why we encourage them, let's say, to take the vaccine, and why we respectfully disagree and would hope they'll reconsider that idea they have about a vaccine if we think that idea is wrong.
I agree with that. And I would, also say that this comes back to, can you understand their perspective, which doesn't mean you have to agree with it, right? Quite pro-vaccine myself. But I do think if someone comes in and is like, absolutely not, and I don't want any shots. I don't want my kid to get any shots. I don't want any of that, stuff infecting my body, and whatever it is that they think that is the problem, that's an opportunity to say, like, let's take a step back. Tell me about what you're concerned with, right? Like, what are you worried about? What do you not like? And again, we can't, again, as Dr. Cohen said, and we know legally, you can't, without their consent, just give vaccines to everyone, but make people get them. But to be curious about what's stopping them and then respond to that. And they might take you up on it, they might not. I do think it's okay. It's with something like public health. And I know this is a hot topic in the context of, like, say, a pediatrician's office. Can they have a policy around, if you're not going to get your children vaccinated, they can't get our services. And, again, I think that is um, both can be warranted and also deserves explanation, that, like, what is it that we're prioritizing here? What's the value we believe in here? Which may, of course, be science, but it can also be public health. It's also the value of saying, like, this matters. And we take you seriously enough to say why it matters. And so creating the clarity up front, I think, is part of that, as well as listening and attempting, when you can, to explain something that might help them see a different perspective.
All right. So we are down to 1 minute. And I really want to thank both of you for being here, sharing your diverse perspectives with our students. I'm curious how you think medical education should prepare our clinicians to handle religious and moral diversity. This is one really wonderful way to start these dialogues, but how else should medical education engage in this space? Dr. Stahl.
Sure. I study institutions where religious pluralism exists. So right now I work on healthcare. I've also done work on the military and religion in these different institutional spaces. And one of the things that I think really matters, regardless of the context, is a willingness to learn. So people are going to come in with all sorts of beliefs, and this can happen at the individual level, as we've been discussing. Can you tell me more about that? But also doing some of the work up front to know where, some of the boundaries and edges might be. What might people believe? If you're grappling with questions around the end of life, different faith traditions have very different ideas about not just what happens, but what is the right thing to do, or the right way for people to die. These are very real questions. There are questions, as Dr. Curlin was saying earlier, that religion engages in about meaning making, and what are the stories we tell, and what are the roles of both humans, and then the things we can do with things like science and medicine in these spaces, as well as the ethical conundrums they may raise. But being open to learning and doing just some of the the reading, the talking, the thinking with other people. And I'll note one thing from my earlier work on the military was that during World War II, the military created this thing called chaplain school. So that's where the chaplains got trained. And one of the things that happened in this space was they would talk about and write in their diaries and letters about the excitement of the sort of frisson of learning about other people's beliefs and other people's traditions and other people's ideas about the world. And so I encourage you, as you're learning the medicine, as you're learning the science, as you're learning clinical practices, to also be engaging with how do people see the world?
Thank you. Dr. Curlin, any final thoughts for us
Sure.
about?
Just a final thought. Certainly, things like this are an encouraging development. I think creating space within medical education for students to reason together about fundamental first order questions that can't be resolved by science. So things like what is it we're hoping for in the face of suffering? What are the limits of medicine? What are the purposes of medicine? Inviting them to reason about that. I would also say medical educators can do their best to avoid a very common thing that gets communicated both explicitly and implicitly, and that is this notion that there's personal values and professional values, and somehow students are supposed to keep those separate and make sure the one doesn't get involved with the other. I would say it seems to me that very counterproductive and hard to sustain that intellectually. Fundamentally, instead, encourage educators to invite students personally to reckon with what is medicine? What am I committing myself to? What's reasonable in these situations? What ideas do I think inform my understanding of that? Kind of make them available to others, get feedback as we together seek peaceably to discern ways forward in all the complexity of good medicine.
Well, thank you both for being here and for challenging us to start thinking about this. Thanks to everyone online for participating today.